coming up. One by Professor Jitendra Saini and other by Professor Ulugang Peti. And first talk is by Professor Jitendra Saini. I'll introduce Professor Saini. He is currently additional professor, Department of Neuroimaging and Interventional Radiology at NMRS, Bangalore. So he did his MBBS and MD in radiology from Oct6, Haryana, and of course DM from STIMST Trivandrum in neuroradiology. He was a senior resident, Department of Radiology at Oct6, senior resident, Department of Neuroradiology at Trivandrum, assistant professor at NMRS between 2010 and 13, and became associate professor between 2013 and 16, and he is currently additional professor at NMRS from 2016 onwards. His clinical research interests are diagnostic, neuroradiology with interest in imaging of movement disorders and brain tumors. He has more than 150 publications in various national, international journals. So with these few words, I would like to invite Dr. Jitendra Saini to start this talk. And Dr. Saini, I would like to tell you, we have 30 minutes. Please take 25 minutes and leave 5 minutes for discussion.
Yes.
Okay, it is over to you, Saini.
Thank you, Dr. Sukur Prakash. My talk is on brain tumors. It's a more of a clinical talk where I would be sharing with you what a lot of new advancements which have happened in brain tumor imaging, and there's a revolution in terms of molecular biology of brain tumors, our understanding of molecular biology of brain tumors. And so I'll try to give a brief overview what has changed in last few years and how it is relevant to the imaging. So this was a 2007 brain tumor classification, in which if you can see that it's just a part of the classification which I'm showing here. You can see there were astrocytic tumors which were graded between grade 1 to grade 4. And similarly, oligodendroglial tumor, which were graded grade 2 and 3, and oligoastrocytic tumors, grade 2 and 3. There's no molecular marker at that time. And all the classification was based on histopathological analysis, which was done on the tissue, which was removed at the time of surgery or a biopsy, and which was then classified based on the morphological features into any of these entities. And this grading was higher was the grade, the poorer was the prognosis. But look at this 2016 brain tumor classification, which I'm showing part of the classification, which deals with astrocytic and oligodendroglial tumors. You can see there's a huge number of entities which have emerged in this particular classification, and the tumors have been tumors are named based on their molecular characteristics, like diffuse astrocytoma IDH mutant, diffuse astrocytoma IDH wild type, and NOS stands for not otherwise specified, because in some situations this mutation status cannot be determined. In countries like India, not every lab can actually determine the status of these molecular markers. So in that situation, the histological features, like astrocytoma is a histological feature, but the molecular marker is not done. So if you, after that 2016, there are large number of modifications which have been suggested, and they are coming as a C-impact updates. There are some 7 updates which have come in last 5 to 6 years, which are actually trying to give more, incorporating more molecular information in the glioma. And this is a summary of a C-impact UTRACT recommendations which came recently, where you can see there are a large number of entities have been added or proposed to be added, and they are all determined by the molecular biology or the molecular or the mutation status. So for example, previously we only knew that astrocytic gliomas are there. Then we came to the point where we said, okay, there can be IDH wild type or IDH mutant type based on the molecular features, but now more and more features are being added. For example, in these cases, EGFR amplification, TERT promoter mutation, to better characterize these tumors and give us a more information regarding their prognosis and the long-term outcome, as well as the treatment. How do we image brain tumors in clinical practice? We do MRS, we do CT scans, which is more used in the emergency, then PET, which is more often used after the treatment, and SPECT. In India, a lot of SPECT is done in the post-treatment situation because it's relatively cheaper and more available as compared to the PET scanning. And what are our aims of neuroimaging in brain tumors? To establish the diagnosis and differential diagnosis, to grade the lesions, characterize their tumor biology, decision-making process for therapy. Then we also use it for planning of surgical and radiotherapeutic interventions. And it can precisely define the location, delineate the lesion, and delineate its relationship to the eloquent cortex, which is the highly functional areas of the brain. And in radiation, when we are planning to give radiation to these patients, imaging and define and demarcate the margins for therapy planning. And imaging is mandatory after therapeutic intervention to monitor the disease and possible side effects. So these are the various MR techniques which are used. Conventional MRI includes T1, T2, FLAIR images, SWI to detect bleed or calcification. Perfusion scans are done pretty regularly now. Spectroscopy is used, some centers use it very often, but some use it in very few cases. Diffusion MRI is used in most of the cases, and DTI and fMRI before the surgical planning. So looking at the lesion characterization is very, very important because, for example, this lesion looks like a brain tumor only, but it's actually a tumor-effective demyelination. It's a kind of a tumor-effective multiple sclerosis lesion, which is actually not a tumor. So we need to characterize these tumor-effective lesions also before we actually try to say that first we have to define whether it's a tumor. It's not a tumor. If it's a tumor, then we go into those different paths. If it's not a tumor, because for example, this particular lesion, only steroids needs to be given as a treatment of this mass, and perfusion is also very low. There's another condition which is very common in India. Actually, you can see there's a brain abscess here. This requires antibiotics or surgical drainage. It's not a tumor. It has got a very different prognosis and outcome as compared to the brain tumor. So these kind of simulating lesions needs to be identified, and not only the tumors. And this is what I'm saying, that for a therapy planning, this kind of tractography and the functional MRI is used, but this is available in few centers. It's not mandatory, but when the lesions are located in an eloquent cortex near the motor area or in the language areas, that time this kind of techniques are used. As I mentioned, that these tumors are now characterized based on IDH mutation. They can be mutant and wild type. And another marker is 1p19q co-deletion. I'll give you a brief summary of all. And based on this, they are defined as astrocytoma, oligodendroglioma, glioblastoma, and mutant or wild type. So I will start with the 1p19q. This is a very specific combined loss of chromosomes, 1p and 19q. And it is a characteristic of oligodendrogliomas, and then tumors which harbor this particular co-deletion or this mutation, genetic alteration, have a much better prognosis compared to those which do not have, because these patients, especially the grade 2 oligodendrogliomas, have a survival more than 10 years. And this look at this survival analysis, where we can clearly see that 1p19q co-deleted tumors have a much longer survival as compared to those which do not have. And so it makes sense to identify these alterations using the molecular methods or using an imaging. These molecular methods include a FISH analysis, which is not available at all the places, and it's an expensive investigation. Looking at this mutation and location of lesions, these lesions are more often located in the frontal lobe. So that's the reason. That is another reason for there being of better prognosis, because they can be surgically resected with less morbidity as compared to the deeper located structures. And we can see some of the radiological features simple radiological features can be useful in prognostication. Look at the survival. Those patients who have a oligodendroglioma or a 1p19q co-deletion and show a contrast enhancement of the tumor tend to have a better, worse prognosis as compared to those who do not show any enhancement. Apart from that, there are so many other conventional features. For example, involvement of the cortex involvement, and very heterogeneous looking tumor, some amount of cyst areas within the tumor. These all can characterize a 1p19q co-deletion in a glioma. And in this particular paper, all these features were compared, and they found that some of these features, as I mentioned, are useful for discrimination. And we can actually suggest that this is likely to be 1p19q co-deleted tumor based on our radiology, based on the radiological findings. We have also done an analysis in our set of our cases, and we found that though these features are useful, but when we do a quantitative analysis, there's hardly any difference between the astrocytic tumors which do not have a 1p19q co-deletion compared to oligodendrogliomas. And only the conventional imaging features, specifically presence of a calcification on CT scan, actually is useful for discrimination. And why it is important, I'll give you this example of this particular patient who came to us in 2013. Actually, he was already taking advice before that also, and undergone 2 scans outside. And in 2013, he presented with this large tumor of the frontal and the temporal lobe, where you can see not much diffusion restriction is there. There's no enhancement within the tumor. 2017, at that time, he refused surgery and didn't, because he was relatively asymptomatic. In 2017, he again came back to us, and we can see that he had, again, the tumor has grown in size, but there's no increased perfusion within the tumor. There's no diffusion restriction on diffusion imaging, and contrast enhancement is not there at all in the tumor. At that, again, he was advised a biopsy and a therapy, but he refused. And then again in 2020, recently came back with the spurt of seizures, and then at that time again we repeat the scanning. You can see that the tumor has grown again, has grown in size and is involving the temporal and the frontal lobes bilaterally. But now also again it doesn't show much enhancement. There's no diffusion restriction, and so this is the natural course of disease in case of a tumor which is 1p19q co-deleted. He underwent a biopsy recently, and he was found to have a oligodendroglioma, which is 1p19q co-deleted. So I mean to say that look at the long protracted course of illness with those who are having this particular mutation. So they have a much better prognosis compared to the other entities, which I'll be showing now. So there have been so many methods, so many attempts to actually characterize. Apart from looking at images in the individual patients, people are using deep learning methods and using radiomics to characterize that whether 1p19q co-deletion is present or not. Recently, there was an interesting paper which came in radiology where they found that the fish, even when we are trying to characterize a lesion, sometimes fish can be falsely negative, and that time we might think that patient is going to have a bad prognosis. But actually, if careful reading of scans can help us to actually identify those patients and actually do other assays like chromosomal microarray analysis, which was done in this particular study, and which can identify the missed diagnosis on a fish. So images play an important role, and they can actually predict, give us a clue that it is a 1p19q co-deletion might be present in a particular case. Coming to another important mutation is isocitrate dehydrogenase mutation. It's a member of enzymes which are involved in energy metabolism, and they catalyze the decarboxylation of isocitrate into alpha-ketoglutarate. And they're present in both cytosol and the mitochondria. And more than 85% of IDH mutations are linked to the arginine replacing histidine at codon 132. So overall, this presence of this mutation in an astrocytic tumor as well as in oligodendroglioma is a very, very favorable prognostic factor. And so coming to its mechanism of how it causes it, how it is linked to the tumor, it is that the cells which are having low level, with the low level, have become more sensitive to oxidative damage when exposed to free radicals and reactive oxygen species. The mutated IDH protein converts at alpha-ketoglutarate to a 2-hydroxyglutarate, which is an oncometabolite. So accumulation of 2-hydroxyglutarate, which is an aberrant molecule, leads to the tumor development. And what is its clinical relevance? Clinical relevance, you can see here clearly those which are IDH mutant positive, mutation positive cases are surviving much, much better compared to those which are wild type. And this is another study which came in NEGM in 2015 looking at the mutation status and survival in high grade tumors as well as grade 2 and 3 tumors. So, so we already know that there are some oncometabolites. This is a very rare condition which is called hydroxyglutaric aciduria. This you can see here that there's a tumor in the right frontal lobe, which is you can see here there's a right frontal lobe tumor, which is, and apart from that, there is the whole brain has got some abnormal signal, and this is a condition which is linked. It is called L2 hydroxyglutaric aciduria, and these patients actually accumulate hydroxyglutarate, and they tend to develop brain tumors. And this is an example of that. We have some 5-6 cases of this particular condition with an associated brain tumor. So oncometabolites are linked to the brain tumor development, as in case of IDH mutation. Radiological features useful for prediction of IDH mutations are looking at the tumor margins, looking at edema, size, enhancement, perfusion, ADC values, and bleed within the tumor. I'll show you some of the examples here. This is a right frontal lobe tumor, which is very well marginated. There's hardly any edema around the tumor. There's no bleed. There's no diffusion restriction within the tumor. Spectroscopy shows elevated choline with markedly reduced Na and presence of a lactate peak. And this is a glioma grade 2 in a 32-year-old female patient. And it was actually on immunohistochemistry, it was found to be a IDH mutant type tumor. This is another case which is again an IDH mutant, but it's a grade 3 tumor. You can see again there's not much enhancement, not much perfusion within the tumor. Choline is elevated. There's no diffusion restriction coming here. So this helps us to diagnose. But in this particular case, it's a wild type, IDH wild type grade 3 tumor. There's increased perfusion. There's enhancement within the tumor. There's increased perfusion, markedly elevated choline creatine ratio is there. And there's a diffusion restriction, which is appearing bright here. And on ADC, it is looking low signal here. This is a glioblastoma grade 4 tumor, which is an IDH mutant here. Here also you can see not much edema is there. Some amount of hemorrhage is there within the tumor. Some areas of increased perfusion are seen. Whereas this is looking a very dirty looking tumor with a lot of necrosis, lot of hemorrhage, and very on the margins markedly increased RCVV values. Diffusion restriction is there. So it's a glioblastoma, which is an IDH wild type with a very, very bad prognosis. The median survival is less than 1 year for most of these patients. And this is another example where you see this patient came to us in 2016. It's an example where how florid the natural history of this, how bad the natural history of these tumors can be sometime. This is an IDH wild type tumor. A lot of hemorrhage was there in this case in the first go itself. Surgery was done. And this is then after surgery in April 2018, 1.5 years. You can see there's now a new tumor has emerged on the right side temporal lobe. At that time, again, surgery was done for this particular lesion on the right temporal lobe. Again, he had another tumor on the right frontal lobe. So look at the aggressive course of disease in these particular patients. So this is an example of IDH wild type. They can have a very, very bad disease, and they usually die within 1 or 2 years time. T2 flare mismatch sign. This is a simple radiological sign which has been described in these particular to determine the IDH mutation. If this sign is present, then this means IDH mutation is present. The lesion will appear very bright on T2 and it will slightly hypointense on flare. So this is a T2 flare mismatch sign. A lot of papers on this have been described. It was originally described by Rajan Jain's group from NYU, and then a lot of validation studies have come because it's a very simple lucid sign which can very easily be identified. There's no special investigation required. Every case undergoes a T2 and flare imaging. So many other features which I described are useful, but then they are not absolutely. In a statistical analysis, they show differences, but then they are not absolute. Like these features can be seen in the other tumors as well. So this is useful, but we cannot, based on these radiological features, we cannot be 100% sure that yeah, this is a mutant, this is a wild type. But they can give us an idea. MRS is one method which can clearly show the presence of hydroxyglutarate, and you can see this was, and it can help us to make a diagnosis of IDH mutation. You can directly see the hydroxyglutarate peak, but and again you can see this another spectroscopy which shows this one, this particular peak, and it has been used in the clinics and used in some of the research modes. No, it has not yet reached in a regular clinical practice because of the intricacies attached with this spectroscopy technique. We actually initially did some comparisons based on comparing the 2 and 3 versus 4, because 4 are mostly the tumors which are actually wild type, and 2, 3 tumors are mostly the mutant type. And we use DTI as well as a perfusion as well as SWI, trying to compare their features and would actually discriminate them pretty well. Apart from that, a lot of studies are using radiomics, DTI, DKI, as well as the perfusion scans, and using artificial intelligence methods along with the radiomics for characterization of these particular tumors. And newer methods like CEST MRI as well as the sodium imaging are also being used to characterize mutations within brain tumors. And there are automated pipelines are being developed which can predict the IDH or a 1p19 code deletions using deep learning and radiomics. Apart from these two, MGMT promoter methylation is another important prognostic and chemo response determination factor, and a lot of imaging features can predict it based on radiology, regular radiological investigation like CT. They're looking at the density, looking at the ADC value, looking at the perfusion. So some of the features can suggest a MGMT promoter methylation. And again, for this particular molecular factor also, a lot of automated methods like radiomics as well as the diffusion weighted imaging is being tried out, apart from CEST and sodium imaging. ATRX is another marker which is usually seen in astrocytic tumors. It is useful because those centers which cannot conduct and FISH for the 1p19q deletion, they can actually interpret differences between astrocytic tumor and oligodendrogliomas based on ATRX. It's not in a resource poor setting, it's a good useful marker. There's another new class of diseases which has been recently incorporated into the brain tumor classification, that is diffuse midline gliomas. Again, they are characterized by histone mutation. They are all located in the midline structures involving the thalamus, brainstem, and spinal cord. Because of their very, very deep anatomical location, their surgical resection is very, very difficult, and only biopsies are done, and then they are subjected to the radiation and chemotherapy. You can see this is a thalamic tumor. You can see that it's a very deeply located and large one and cannot be surgically resected. But again, the mutation status determines the prognosis, because those which are mutant tend to have a very, very bad prognosis. This is a wild type tumor which doesn't show much enhancement, not much perfusion, but because of the deep-seated location, they have a very bad prognosis. In conclusion, imaging of brain tumors is undergoing a major transformation with recent advance in both imaging and improved understanding of biology of brain tumors. And imaging can play a very important role in both identification of some of these molecular markers as well as giving a reasonable prognostic information, because any brain tumor patient who is diagnosed to a brain tumor, first question which he asks usually that how long he is going to live and what is going to be his quality of life. So these are very, very important factors, and imaging can actually help in giving some of these answers. Thank you. And I acknowledge all my colleagues who from neurosurgery and neuropathology and my own department who help us in collecting this information. Thank you.
Okay, thank you, Dr. Saini, for completing it well in time. We have a couple of minutes for questions. If any of the participants have any questions, please raise your hand. Then
can I come in, Suri? Jagannathan.
Yeah, please come in, Jagannathan. Yeah.
Yeah. How are you, Saini? Jagannathan.
Good evening, sir. I'm fine, sir.
Yeah. So just a small clarification for my own sake.
Yes, sir.
You referred, no, that was it an IDH who was longitudinally followed up and we were not able to do it.
Yeah. So there were two cases which I showed longitudinally followed up case. One was 1p19q co-deleted who survived for a very long time. He's still alive. The other patient was an IDH wild type case who had a very stormy clinical course and died within 2 years of the diagnosis.
Okay. You didn't do spectroscopy for these two patients because that would have given some indication at an early stage.
Yes, we did spectroscopy, but for determination, yeah, all the brain tumors in our center usually undergo spectroscopy. But
I know. Yeah, because you people do it regularly almost.
Yes.
Yeah. So, okay. Yeah. And the other question is, have you also monitored some of these patients longitudinally through the DTI?
Yes, DTIs. We regularly do DTI in these patients, but we for longitudinally we haven't found much use, because first case I showed you all the cases, all the time points I showed the diffusion weighted imaging, and it all never showed diffusion restriction in last 8 years. This patient is coming to us for last 8 years. Whereas the second case which I showed had a diffusion restriction in all the time points. When the patient had a tumor on the left parietal, that time also had a diffusion restriction was present. When had on the right temporal, again the diffusion restriction was there. And when the patient had a right frontal lobe, that was also restricting tumor. So it was always a glioblastoma, very cellular lesion, so always showed diffusion restriction.
Okay. I may be wrong, because you are a neuroradiologist, you know much better than me. Suppose you have a patient who's having a progressive tumor, right? And then you are doing it longitudinally. Can DTI give you an indication whether it is going to sort of impinge upon very vital cognitive areas by in 1 or 2 steps of DTI?
Yeah, it can. This kind of information can be provided. We like, for example, this first the case which I showed, who survived for 8 years. First time when he had a tumor, it was on the left frontal and the left temporal lobe, and it was actually coming near the language areas. That time he was explained about it. Now
this is exactly what I was thinking about. Yes. Yeah. That's good.
Next, Grace.
Thank you.
Grace?
Yes, Suri, thank you. Very nice, informative talk. My first question is quite new. You mentioned about this 2-hydroxyglutarate, which is an oncometabolite. I was just wondering, this is a common metabolite everywhere in the body, is that right? Why should it trigger a brain tumor? Is that patient, can they get tumors in any other part of their body also?
No, so I'm not very sure why they are associated with the brain tumors only. But yes, as I showed one case which is a rare metabolic disorder in which also this accumulation happens, they tend to develop only brain tumors. They have of variant types, mostly gliomas. But I'm not very sure can they trigger in other parts of the body.
Okay, my other question is, you also mentioned about sodium imaging in MGMT gene methylation tumors.
Yes.
How much is the sodium levels? Are they higher in these tumors, or are they lower? Because I know that we have 150 millimolar sodium chloride generally, right?
Yeah, so in that study they showed that those which are having, it was a very small sample size, because probably that sodium is not done regularly in the clinical practice and it's a difficult technique. But they showed that those who are having methylation, they tend to have a lower sodium levels compared to those which are unmethylated. But I don't know. This is a very small few number of cases were there. I don't know how much valid it is, but it was just a pilot data which probably authors presented.
Thank you.
Next, Vivek has a question. I think he wanted to ask.
Yeah.
Are you there?
Okay, sir. Yes, sir. Yeah. Very nice talk, Dr. Sani. So 2 quick questions. So whenever you're saying that so you are having the imaging features, and let's say for the last question where Grace asked that sodium level and then correlating with the MGMT status or other genetic mutation status. What do you think? It looks like just a fishing, right? It is an exploratory study where you are just trying to, find out a relation between imaging feature and a genetic mutation. So
yes.
How do you see this this kind of like studies? Is it a phishing, or does it come with certain kind of background?
No, I would put it in this way that these are more of exploratory studies, because they are, and because just for example, just doing some, let's say 15-20 cases and trying to say one level is higher than compared to the other level. These are just exploratory. They do not really have a, they are not saying that this is, they haven't really put a biological basis for that, but they have just said that certain observations are there, for example, difference in sodium levels. But I don't know whether they really going to make much of difference. I give an example in a spectroscopy study, which clearly, which itself shows hydroxyglutarate has not been able to transform in a clinical tool. So where we can see the molecule directly, whereas in this particular studies we are saying, okay, there's some levels are different. We don't know what is the biological meaning of that.
Okay, any other question? I don't see
And
any.
second question was like, do you have the capabilities? Sir, one last question.
Yeah, please go ahead. Yeah, Vivek, please go ahead.
The second question. Okay. Sir, Vivek here. Can you hear me? When you were showing the data that was acquired here at NMRS. Yeah. Can you hear me, Dr. Saini?
Yes, I can hear you.
Hello?
Hello, I can hear you.
You go ahead, Vivek.
Hello, can you hear me?
Yes.
Okay, so I'll see 2Hg optimized or 2Hg tailored or a spectroscopic sequence method that could actually identify 2-hydroxyglutarate. I saw there was a short echo time MRS data where you will be having mixed glutamate and other 2-hydroxyglutarate residues. So how do you confirm that you are confident of the 2Hg?
Yeah, okay, but yeah, definitely that is true.
I completed my question.
Yeah, I understand your point. What I'm saying is that there are some people who have tried to actually identify hydroxyglutarate in a resected tissue using other methods, and they have found some of the samples have a discordance where it has shown hydroxyglutarate in vivo, but when they took out the sample they didn't find it. So I mean to say there is some discordance, but such literature is very, very scarce. I mean,
right.
And probably that's the reason difficulty in identifying this peak, and such a small peak which we find on spectroscopy, it has not been able to get into the clinics. That's one of the reasons behind that. Probably a more robust method, till we get a more robust method which can be done in a clinically relevant setting in a few minutes time, it won't transform. I understand your point that you are saying that what you are seeing is how confident you are that it's an hydroxyglutarate. Why can't it be something else?
All right. Yeah, we'll discuss more later.
Okay. I don't see any other hands raised. So I would like to take this opportunity to thank Dr. Saini for excellent presentation. Thank you very much. Okay, we'll move on to the next talk.
Okay, sir.
So Dr. Saini, you can now take over. Okay. Start sharing his series.
So that.
Yeah. Okay. Yeah, let's see. Second talk of this edition, it is Dr. Wolfgang Petty. He is currently professor in chemistry and biochemistry department at University of Arizona. He got his PhD in 2001 from the University of Frankfurt. He worked with Professor Christian Grissinger. He was a postdoctoral researcher during 2001 to 2004 at Scripps Research Institute with Professor Kurt Uttich. He was assistant professor. He was assistant professor and became professor, and from 2004 to 2016 at Brown University. He has several awards and honors. In 2017, he got Homer C. and Emil Davis Witt Chair. From 2015 to 2017, he was a permanent member of the American Diabetes Association's Research Grant Review Committee. From 2016 to 2020, he was a permanent member NIH MIST, Molecular and Integrative Signal transduction study section, and from 2017 till date, he's the associate editor, Journal of Biological Chemistry. With this short introduction, now I would like to invite Dr. Wolfgang Petty. Petty, it is over to you. You have, please take 30 minutes, 25 minutes plus 5 minutes for discussion. I invite you, Dr. Petty.
Thank you very much for the kind invitation and the very kind introduction. It's a pleasure to be here, and it's a pleasure to introduce you to some of the work that we are doing in my laboratory. And what we're interested in is understanding the function, the specificity of enzymes, but particularly of protein phosphatases. So what we are interested in is actually, we are trying to understand how we can switch biology. And one way that we switch biology in our body is that we use post-translation modifications. And one of the most famous post-translation modification is certainly phosphorylation, which can happen on serine, threonine, and tyrosine residues. And in order to allow that to happen, we have to have enzymes. And one of these enzymes that allow for these phosphorylation reactions to happen is kinases. But if we want to switch biology, turn something on and turn something off, we also have to have an off switch or maybe the on switch, and that's the phosphatase. So we know a lot about kinases. All of us have probably seen and read hundreds and hundreds of papers of kinases, of thousands of papers. And we know them also because they are key drug targets. We know much less about phosphatases, and I will tell you a little bit about why that is actually the case. It's interesting to see. It seems like the kinase guys are always ahead of us and smile a little bit, and we are the much more serious, despite the fact both of these areas are rich of Nobel laureates. And as you can see here from these papers, first of all, both of those.
Excuse me, yeah. Your slides are not moving.
My slides are not moving. That's not a good thing. Are they moving now?
No, not yet. It is not in the slideshow mode, I think. Now
moving.
Okay. Now okay. Okay.
Now it's okay? Okay. Thanks for letting me know. That's a very good point to know. So I'll let you know. I told you about kinases and phosphatases, where the kinase is the much more prominent enzymes that we're knowing that allow the phosphorylation to happen, and the phosphatase is the much less well known. And I told you about that both areas have been studied for a very long time. Indeed, you can see here phosphatases were known before kinases, and both of those were actually first published in the Journal of Biological Chemistry. Both of them are rich in Nobel Prizes. And why are these guys laughing so much more is because we know about 10,000 confirmed substrates, or a little bit more nowadays for kinases, while we know about 400, and that's a very generous numbers for the phosphatases. And the reason why there is such a big difference is that kinases have this active site recognition sequence, which means if I want to know if a pKa or a CDK1 or a Aurora B kinase is active, I look at the active site recognition sequence and I can make a good guess. It's easy to confirm and allows me to work for it. And while we don't have these type of sequences for phosphatases, which recruit them in recruit their substrate in a completely different manner. It's a much more complex manner. What we are focusing on is this subgroup, this PPP protein, phosphoprotein phosphatases. This is it's a 7-member group, which is responsible for about 98% of all serine, threonine, dephosphorylations. What do they have in common? Their active site of all 7 members is 100% conserved, showing you that the action of substrate recruitment and specificity must come from areas that are quite far away from the active site, which makes inhibition also a very tricky issue. Nevertheless, what I will tell you today is one specific issue about protein phosphatase that's called the protein phosphatase 2B or 3, or much better known as calcineurin. This is a ubiquitous serine threonine phosphatase, very prominent in the brain. 1% of your brain mass is calcineurin. So this is a protein that exists out of two expressed proteins, the calcineurin A subunit, which includes the catalytic domain. And what I show you here, this is the active site. So all of these proteins are metal activated enzymes, which carry a zinc and a manganese and iron in order to allow for water to be activated, which allows for the hydrolysis of the phosphate group. And they have a binding domain of CNB, and CNB is this gray subunit here that binds to the CNA binding domain that I show you here. This is a calcium sensor, and once it's calcium loaded, it's the active state. There's a couple of other things happening for activation, but this is the key picture that you should keep in mind. So how does calcineurin recruit substrates? So we have shown over the last couple of years, and we and other groups have shown that there is intrinsically disordered proteins that have specific short linear motifs, which are short, maybe 4 to 8 amino acid longs, primary sequences that are specific for the interaction with these phosphatases and other proteins. And for calcineurin, we have two sides. The one side I will call the Pixid side. I leave that X out because it's impossible to pronounce. And the second side is the LXBP side. Those are the two sides that are known to be substrate interaction sites, and they use these slim sequences. And these sequences are part of substrates. These sequences are part of inhibitors. These sequences are part of any regulatory protein that wants to bind on specific complementary grooves on the surface of calcineurin. And because these groups are so specific, we've developed a technique that we call a structure-based shape complementarity, or SBSC approach, to identify novel calcineurin regulators. I won't talk about that at all, but this has really allowed us to push forward the type of substrates calcineurin can actually see. There's publications out there, and there's more in the works, and we are about up to really close to 700 substrates that we now start to have fully confirmed. So really we are able now to go to see how biology is switching if we have correlation between kinases and phosphatases, what I pointed out at the beginning. And that really allows us to come up with a completely new, what people now calling calcineurinome, or what I would just say is a set of substrates that have specific biological functions. You can see it plays a huge role in all aspects of biology. It was clear that it's important for transcriptional regulations because the NFAT proteins were the substrate that we all know for calcineurin, but it has a large array of other functions that we are now finding out and learning more. And one of those regulators is the plasma membrane sodium proton exchanger 1, or NHE1, also called known as SLC9A1. And so this is a integral membrane protein, and it's basically the cellular pH meter. Okay, this is the protein that makes sure the pH of the cell is steady. And it has a very complex structure. You can see that calcium is probably important. It has a calcium modulating or binding domain. It has a couple of other domains. It binds by a lid and interacts in variable ways with the membrane, as well as it has the transport domain. But this transport domain is regulated by the C-terminal domain here, which is heavily phosphorylated. And what we identified using our SBSC technology is that we predict here to have a Pixid and an LXBP site. And we were focusing on that and seeing what kind of biological functions these domains have. So when we look at these C-terminals, we can do NMR spectroscopy with this very rapidly and very easily. And what we can do is we can do and what you can see, this is a completely disordered domain looking at the NMR spectrum, which doesn't have any chemical shift dispersion in the proton dimension that I show you here, simply for the reason is there's no hydrogen bonding network in these proteins. So when we add calcineurin to that, that's the black one, we can see a number of peaks lose intensity, typical for this intermediate exchange regime interactions that IDPs have with folded proteins, and thus allows us to show us where the binding interaction is. And indeed, you can see that we have a reduction in intensity at the areas that we predict to be the LXVP and the PIXID side. And interestingly, even the area that was linking these two areas, we have a reduction that we were surprised to see. We don't see that for many other proteins. So to confirm that we did quickly ITC, this is really a tight binder, 60 nanomolar. When we delete the LXVP site here, we get an 81-fold reduction, really showing, yes, that's the LXVP site, that's confirmed. We just use a peptide, it's even weaker, showing that this has kind of a type of avidity effect here of binding. Then we have the PIXID area. When we delete the PIXID sequence here, we have a 41-fold reduction here, and the peptide again is weaker, showing that probably this linker confirms avidity of binding. And we understand that we identified now the LXVP and the PIXID side. You know, this is all good when we do it in an NMR tube in the ITC, but we want to see it in cells. This is MCF7 breast cancer cells. PLA assay really nicely showing you exactly that these proteins co-localize, and we can actually see that. So then we went forward and said, like, good, we know that this is a real interaction, and we want to understand how this interaction is working. So then we tried to crystallize that core binding domain with the LXVP side, the PIXID side, and this linker to calcineurin. And what you can see here, all we found is actually the PIXID side and the LXVP side, how it's binding. This has been seen before. I won't go into any details in this study. But again, we did now these mutation studies in a cellular assay showing again that this is exactly the interaction. I want to come back to this linker. I told you this was very unusual. Usually I see a reduction at the PIXID side, I show a reduction at the LXVP side, but I never show the reduction with this linker. So when Sindru, who did most of that work, she was a grad student in the lab, did that, she made a nice model that I show you here and says, like, this is not a lot of residues that link these two sequences here. It's about, I think, 22 residues. There's a very limited way based on geometry, how this linker can actually interact. But one thing you can say is it seems to be always going over the active site here. So how is that linker actually localized to this? And when we look at the electrostatics of this interaction here, we saw that there's acidic patches on the top of the molecule calcineurin here. And then we looked actually at the sequence here, looked that there are two arginine sequences here. And Sindra was able to put them in, and based on the model where she actually didn't even think about that this could be a possibility, you can see that these arginines are really very close to these acidic patches here. And we thought this is an interaction where there's a charge-charge interaction that we have now, we and other groups have now so much seen plays key important roles in biology, which allows the molecule now bind in a very dynamic way where it basically slides over the top of the molecule, but doesn't get locked in, but has a very tight KD, basically meaning it doesn't matter where this arginine or this arginine binds to this patch, or this patch, it will always have the same binding affinity, but delta S is much different for this interaction if it would be locked in a single state. And how can we lock it in a single state? Well, we can make a RA-RA mutations where we mutate the arginines to alanines, and you can see the KD stays the same, but as predicted, delta S is changing quite dramatically, showing in this case here, we lock it in a single conformation, losing the ability to have delta S being there, but it was compensated by delta H. In this case here, there is less delta H here, but preferable delta S is not that restricted because it can move around. And we find this interaction really important for the regulation of these enzymes here. We have published now a couple of papers about it, and I can just tell you, I think this will be really key to understand selectivity. And we thought about this as a flexible windshield wipe, but it actually blocks the enzyme there. Again, we can confirm that by NMR spectroscopy. We see there's less interaction or a more restricted interaction when we have this AAA type of molecule here. And Sindra again went nearly crazy and tried to get the crystal structure here. And unfortunately, it wasn't tight enough to really lock it down by crystallography, showing that NMR in this case, and actually ITC and NMR in combination, is the only way to identify these interactions. Crystallography is not a choice to do. So we wanted to know how it becomes selective, and really that was the key question that we were after. Well, what did we do is, well, we can phosphorylate this C-terminal tail. It's mainly phosphorylated by MAP kinases, ERK2 and P38. We showed that JNK. We get 6 phosphorylation sites here distributed throughout the molecule. And the question was, what is happening when we make then dephosphorylation assays? And what we use for these assays is always NMR spectroscopy. We in the lab think we use a lot of antibodies, but the best antibody that is really not an antibody is NMR spectroscopy. Especially for intrinsically disordered proteins, we can readily see the shifts in the peak that are phosphorylated, and we can see the loss of the peak when we have dephosphorylation, getting very accurate kinetics of phosphorylation and dephosphorylation allows to see. And the outcome here for the NHE1 domain is dramatic. You can see that there is nearly no dephosphorylation for 5 of the 6 phosphorylated sites, and one site becomes dephosphorylated. That was the reason why I told you that maybe kinases are very unspecific and the phosphatase is the specific things, and we see this now for more and more and more examples. So the question is, why does it become so specific? Is it the threonine residue? You can see here, this is the only threonine. All the other sites are serines. So what we did to answer that is to turn that threonine into a serine, which really indeed slowed down the dephosphorylation, but it was still the fastest dephosphorylation here. And moreover, if we turned another serine into a threonine, this did not have the same effect. It didn't increase the speed of dephosphorylation that much, showing that there's something unique of this site much beyond the threonine residue there. Okay, that's good. So the other questions that we have, has anything to do with the LXVP and the Pixit site, the docking motif? Are these just like motifs that try to draw it in and allow for the phosphorylation to happen, or also are they important for selectivity? Well, there was the LXVP site that we tested. We deleted that site here, and dephosphorylation became very quickly. And that makes some sense because when I don't have binding now to the LXVP site, that linker region, that windshield wiper, the electrostatic interaction is not available, that blocks the active site anymore. That allows for a very rapid dephosphorylation to be happening, exactly what we thought it would happen here. And when we delete the Pixit site, we slow the interaction down, and that basically just have to do is because there's not, the phosphorylation sites now are not as close to the active site, they're much further away. Logically, that would take more time to actually engage with the active site. So while they play a role by bringing it in close proximity, you do not play a role in regards to selectivity. Perfect. Again, let's go back to this charge interaction that I show you. How important is that? Let's do the dephosphorylation reactions, once with the wild type protein and once with the AA protein. Look for the difference here. And indeed, the AA protein has a faster dephosphorylation rate, meaning that there's better access to the active site. It's clear. When this is in one position and doesn't work with a windshield wiper, it's much easier to exit. When you have that windshield wiper, you have to find a spot to go in. If it's just stuck in one position, it's very easy. The rain can drip on the active side, or the substrate can bind to the active side, and dephosphorylation becomes faster, exactly what we see here. But it's not the key part here. So we were kind of like stuck here and thought, well, what is happening with this? Is there really something around the active site that we overlooked? And nobody has ever seen an active site recognition sequence or any phosphatase. So we were kind of getting very, very confused about what was going on. So when we look back to a very old structure, and there is what is called an autoinhibitor domain that can bind over the active side. This is part of the A subunit of calcineurin that I introduced to you before, and it's well known that sometimes this intrinsically disordered region of these proteins can bind over something and block the active side. This has been seen for many other signaling molecules, and this is true also for the AID. And there is an ERMP sequence that seems to be binding to the active side, with the E mimicking the phosphorylated states and plugging the active side. So we compared it to our dephosphorylation side, and the one thing that we saw is that our specificity sequence, the T779, actually has a T and a P here as well. So when we look, and that, so we thought, well, maybe that P is actually important for the interaction. Basically, soon was nearly out of desperation because we didn't know what else to do. Well, desperation is a good weapon when you want to do science sometimes, because what we saw here was, this is the sequence. When we turned that into an A, we lost quite dramatically selectivity and speed of dephosphorylation. So clearly that P is important. So as a second experiment, what we did is we turned this serine 785 site into a TPAP site. This is exactly the site here, that exactly the sequence that was this TPAP site of 779. So we basically shifted this site from here to over here and mutated that site, so this cannot be dephosphorylated. And what is happening now? Boom. This is exactly this site is exactly dephosphorylated with the same speed as the T779 site in wild-type protein. So it is really indeed this sequence that is the key part for dephosphorylation. So what is happening here? Well, this is part of a structure and part of the model that we created here. And what you can see here is that this proline is sandwiched between two hydrophobic residues, a tyrosine residue and a histidine residue. So when you now put in our sequence, the PTPAP sequence here, you can see that this fits perfectly in here. And one important thing that I should show you is that this histidine and tyrosine residue is only conserved in calcineurin, and none of the other members in the tyrosine phosphatase, in the phosphatase family here, meaning that's a reason why there is selectivity on uniqueness, if that would be true, in recruitment for their substrate. So Sinro deleted those two, made an a crystal structure. You can see how shallow this pocket got. There's nothing there anymore here to really interact with those. And indeed, we get a reduction in the dephosphorylation efficiency due to the weaker interaction that we have here. And I should say, we have now this confirmed for a number of substrates of calcineurin, that this is a key pocket for the interaction. It's also working for a couple of other proteins, and indeed what we just have published, that it's not just this pocket here, but also the neighboring pocket that allows you to bind even tighter, and you can make a really nice inhibitor if you take both of those sites here and block the active site. And lastly, it's all good when we do that in vitro. We want to know what is the biological functions. Well, we knew now that suddenly this T779 is really a key phosphorylation site. What does it do with the function of NAG1? And this, what I show you here is when you have the A mutant, the wild type protein in the A mutant and the D mutant, you can see there's a huge difference in the activity of the NAG1 receptor. Indeed, this was done in cooperation with Sine Petersen's lab in the University of Copenhagen. And there's not an other example that shows this type of regulation of the NAG1 receptor membrane protein. And really, this must be a key part of how we regulate our pH sensing module here. And Stine is working on the details of this right now. And with that, I want to close to give you an example how we use NMR spectroscopy. As I mentioned, Sinro did a lot of this work. Young is really driving that field of calcineurin research in a very dramatic way, how I think. And my other co-workers that I've done a work, this is our PP1 expert. Meng Senta is our biggest expert in NMR spectroscopy. He is fantastic and has done the most crazy things. He's working right now on 100 kilodalton plus proteins to get really full biological information of those. Christiane does a lot of work on enzymes and how they're regulated using NMRS. So does Everton and Marta. And all of that is a collaboration with Professor Rebecca Page's laboratory. Sparky Clarkson is always working on all NMR. I mentioned before our collaborators at the University of Copenhagen that were essential to do that. This is our funding mechanisms. And as I was mentioned before, I'm associate editor for a Journal of Biological Chemistry, and I want to thank you all for submitting your papers to the JBC. We were very happy that we can serve the Indian science community, and I'm happy to answer any questions that you have. Thank you very much.
Grace, are you there?
Yes.
Please go ahead. Yeah.
Yeah. Thank you. That was a fantastic talk. I was wondering about your first initial NMR titration. Since it is a nanomolar binder, the line broadening, was it due to non-deuterated proteins, or have you tried using deuterated protein?
This is a fantastic question. Thank you very much. Yes, you're right. So it's most likely due to, basically the idea is here we have the intrinsically disordered protein and we have an interaction at the nanomolar scale. We bind something large to it, such as calcineurin, which is 60 kilodalton, which means at this point the whole complex is nearly 75 kilodalton. This is not deuterated correctly. Thus, the interaction will lead to line broadening because of shortening of T2, and that's why we can see it. Can we iterate NHE1 and show changes in the chemical shifts? Yes, we can. We haven't done it with NHE1, but we have done it with a plethora of proteins that interact with PP1 and other proteins. And yes, you can show that. We usually don't do that anymore because we think most of it is due actually to line broadening. And so we can be pretty confident about that. And we follow up with ITC to basically nail it down. But we could also do certainly the way of showing the chemical shift changes. Why we can do that so nicely without, I think, deuteration is the fact is there's no long-range interaction in IDPs, meaning all the peaks that are gone are mostly the peaks that interact directly with calcium.
Thank you, Dr. Kuti. Any other questions?
Can I ask one more question? Sorry.
Okay, please go ahead. Yeah.
I was also wondering about this phosphorylation. Is that a sequential process that, because this residue T779 is quite far from the binding site, so does it have to do with the first initial PXIXIT motive binding, and following that LXVPR, I don't know which one happens first, that triggers the T779 phosphorylation? Is that how it works?
No, it's not how it works. We were having the same thought that you have actually when we did that. But we basically, you can take the TXXP sequence that I introduced to you and have different distances, and the speed of dephosphorylation is identical. I can put it as far away as 200 amino acid and we'll always find that sequence because it has a stronger KM over any other sequence. The PIXID and the LXVP side are important to bring it in close proximity, in close-ish proximity if you want so. But the distance we have tested, I think, if you put it at 50, 60, 80, 100, 150, the speed stays about the same. At one point, it becomes a little bit slower simply because it takes probably longer to find the active site just by random interactions. But yeah, so we have tested that. So it's really the sequence. The slim sites are important to bring it in close proximity. That TXXP sequence is the important one for the KM of the dephosphorylation reaction.
Thank you.
Okay, thank you, Dr. Petty. Yeah, I don't see any other hands raised. So I'd like to take this opportunity to thank you, Dr. Petty, once again for an excellent talk. And I would like to take this opportunity to thank both the speakers of the day. And I'm going to share the poster of the next week. So if you can,
Oops, sorry.
you can remove your slides, okay. Okay, this is we have, oh no, I'm sorry, not this.
Again?
No,
You
no.
have a you have a PDF file, sir?
You cannot come back again. I am unable to open it. Okay. No, I'm not able to see that. I don't know why it is. Okay. Oh, I have it here. Okay, let me see it.
Shall I share it?
Yeah. You can share it, Jeet. You have it?
Yeah.
Yeah, please.
Yeah, we both can, neither can, yeah.
Yeah, it is there. You can share it. Okay. These are the two speakers for the next edition, which is on 13th October. I would like to draw your attention to one important thing. Please note the change in the timings. Since the speakers are one from Japan and one from Australia, so it was really a challenge for us to find a time convenient for everybody. As you know, the 7th or 7:30 here, it will be more than 1 hour past midnight at Melbourne. So we had to little bit alter the timings. It's only for the next week. If the talk is at 7:30, we'll begin the session at 4:30 with the talk by Dr. Mark Antonisani and then followed by UCK Nishiyama's talk. So this is the only change for next week, and we'll meet again at 4:30. Thank you very much for all your attention.
Bye, everyone.
Thank you.
Thank you.
Thank you everyone. Thank you, speakers. Yeah, thank you, sir.